Hi, I'm Nate. In this video, we're going to talk about ectopic pregnancies. An ectopic pregnancy is a pregnancy that has implanted outside of the womb, essentially one that is misplaced. You know, when your partner tells you to always put the house keys on the right side of the coffee table, but you think you know better and now you can't seem to find them. No? Let's move on then. And apart from a few rare cases, the pregnancy has to grow inside of the womb in order to be viable. If you're one of the few rare persons who hasn't yet subscribed, click on the subscribe button. Thanks. In the UK, ectopic pregnancies occur in 11 out of 1,000 pregnancies, and sadly, 2 mothers out of 1,000 ectopic pregnancies will die from complications. When the pregnancy is not in the womb, it is commonly found in the fallopian tube, which comprises 95% of all cases of ectopic pregnancies. Other common sites of an ectopic pregnancy include the cervix, the ovary, the abdomen, and if you've had a previous cesarean section, the scar of the womb. Sometimes, an ectopic pregnancy may exist in the presence of another pregnancy inside of the womb, which we call a heterotopic pregnancy. There are certain situations which can increase the risk of having an ectopic pregnancy. They include having assisted reproductive treatment, like IVF, or if the tube is scarred by previous pelvic or sexually transmitted infection, endometriosis, or surgery. Although intrauterine devices are effective in preventing pregnancies, if they fail, there's a higher chance that the pregnancy may implant outside of the womb, and women with previous ectopic pregnancies are likelier to experience another. However, it's important to note that a third of ectopic pregnancies occur without any risk factors. The symptoms of an ectopic pregnancy, especially one in the tube, can be vague and can be very similar to other conditions which can occur in the first trimester. They include lower abdominal pain, pain deep inside of the pelvis, vaginal bleeding which can be heavy, pain or problems when passing urine or opening bowels, or a fainting or dizzy sensation. These symptoms can represent other conditions like a miscarriage, urine infection, appendicitis, an ovarian cyst, and so on. The main concern with any ectopic pregnancy is heavy internal bleeding due to the rupture of blood vessels within the pelvis. If you're pregnant and you're having severe abdominal pain, heavy bleeding, shoulder tip pain, or dizzy spells, it's important that you present yourself to the emergency department as soon as possible. In most other cases, contacting the early pregnancy unit or the GP are reasonable options. When in hospital, we'll perform several tests, including a urinalysis, urine pregnancy test, blood tests, and we'll monitor your observations, including heart rate, blood pressure, and oxygen saturation. When stable, the best way to diagnose an ectopic pregnancy is with an ultrasound scan, ideally transvaginally, which is when the ultrasound probe is inserted into the vagina, which often gives us better image quality. The ultrasound scan can tell us whether the pregnancy is in the womb or outside, whether it's a miscarriage, whether there's blood in the pelvis, which can be concerning, or if there are other causes for the pain such as ovarian cysts. The pregnancy has to be of a certain stage in order for us to see it on the ultrasound scan, otherwise it will be too small for us to identify. If we can't identify the pregnancy for a person that has a positive urine pregnancy test, we would advise performing a blood test called beta-HCG and repeating it 40 hours later. We then look at the difference between the two levels. For a viable pregnancy, we expect the HCG level to double every 40 hours, which is less likely to occur with an ectopic pregnancy. From this point of the video, we're going to focus on the commonest type of ectopic pregnancy, which is the tubal ectopic. There are 3 ways we can manage a tubal ectopic pregnancy: conservatively, with medication, or with surgery. When it comes to deciding which of these is most appropriate, your healthcare team will discuss with you both the benefits and risks of each of these options. There are several criteria which we use to decide which is the most ideal option. They include the symptoms a woman has, the ability to attend multiple follow-up appointments, the blood HCG level, and the ultrasound findings. When managing conservatively, we're hoping that the pregnancy will abort spontaneously. This is a good option for women who have no symptoms and a very low beta-HCG level. Women undergoing conservative management will require regular blood tests to confirm that the HCG level is falling consistently. They may require up to 3 blood tests in the first week, followed by weekly blood tests until the pregnancy has ended. If the HCG level is not falling and you're starting to experience symptoms like pain, your clinician will discuss with you alternative ways to manage the condition. The medication we use for ectopic pregnancy is called methotrexate, which is also the same drug that is used in some people with rheumatoid arthritis or as a chemotherapy treatment. This is an option for women who have little or no pain, a HCG level that's less than 5,000, no viable pregnancy within the womb, and has no contraindication to receiving methotrexate. Methotrexate is given as an injection, and additional blood tests will be required to check that the liver function is normal. It can come with side effects, the commonest being stomach cramps. Women receiving methotrexate will require regular blood tests to confirm that the HCG level is falling within the expected target. If it isn't falling or is falling very slowly, your clinician will discuss with you the option of either having a second dose of methotrexate or to proceed with surgery. Women receiving methotrexate are advised to use effective birth control methods for 3 to 6 months, as the medication is known to cause severe defects in pregnancy. Surgery is often done as a keyhole procedure, which we call a laparoscopy. However, there may be instances when an open procedure is required, for instance, very heavy bleeding, or if there is a complication arising during the procedure. We would usually advise the removal of both the fallopian tube and the pregnancy, which we call a salpingectomy. However, there are instances when we would aim to preserve the tube and only remove the pregnancy within it, called a salpingostomy. For instance, if the other tube appears abnormal, if there are fertility concerns, or if this is your preference. It is important to note that women who had a salpingostomy will require regular HCG blood tests after surgery, and up to a fifth of women will require further treatment by means of methotrexate or additional surgery, as there can be pregnancy tissue remaining within the tube. Surgery is strongly advised for women with significant pain, or if the scan shows a pregnancy beyond a certain size or with a heartbeat, or if there's significant amount of blood within the pelvis. If your blood type is rhesus D negative, you'll be offered an NTD injection following surgery to prevent complications for future pregnancies. For women with fertility issues and is diagnosed with an ectopic pregnancy, we would advocate for either conservative or medical management over surgery as long as all options are safe, as this improves future chances of conceiving. In subsequent pregnancies, we advise women to contact their local early pregnancy unit, as they may consider an early ultrasound scan due to the higher risk of having another ectopic. Reassuringly, most pregnancies will be within the womb. Give this video a like if you found this helpful. Share, subscribe, and I'll see you again soon.